Okay, let's just continue with an overview of topics. Okay, so here we'll go through the slide and then we'll start. So aero chambers, well, an aero chamber is just to help patients get the medication of an inhaler into their lungs. Okay, and so we use meter dose inhalers of different medications. We attach the meter dose inhaler to the end of it, and the chamber is put then to the mouth. And when the MDI is squeezed, it puts the medication into the air chamber to then be inhaled. So how does that help? Well, the patient doesn't have to time the sequence of when they press the MDI and when they inhale. Okay, because that can be really difficult for patients. So it just allows more of the medication to be deposited into the lungs. Okay, a nebulizer is where we'll put liquid forms of medications such as albuterol or ipratropium into a nebulizer, and then we'll run oxygen through the nebulizer, and then with a face mask or some kind of mouth attachment, it'll be misted and they'll inhale the medication. Okay. There's also dry powder inhalers. So instead of MDIs, which are basically puffers, there's dry powder inhalers where you just twist the inhaler, and then there's a powder sitting in there that the person puts to their mouth and just inhales it. Okay, so they're also available. So, for example, you wouldn't need an aero chamber with a dry powder inhaler. Okay, let's just talk about some medications. So, medications for bronchodilation. So, whether it's for asthma or COPD or someone that's just wheezing and we have no idea why, well, we can use bronchodilators, such as a beta-2 agonist. Typically, albuterol is a common one. Okay. There's also bronchodilators in the anticholinergic group. So they work by blocking this parasympathetic system to the lungs and allows for some bronchodilation. So beta-2 agonists and anticholinergic inhalers are bronchodilators. Methylxanthians, well, that's theophylline or some kind of variant of theophylline, and that's usually in a pill form or IV. We don't use theophylline very much anymore. It's like a coffee derivative, so it has a lot of the side effects of coffee: anxiety, jitteriness, tachycardia. It has a bit of diuretic effects, so patients urinate more. And it has very weak bronchodilator effects. Plus, theophylline has a lot of drug interactions with other medications patients are taking. Okay, so I think you'll have to know theophylline, but just know that we just don't use it very much anymore. It's not highly effective, and it has loads of drug interactions. Okay. A SABA, what's a SABA? A short-acting beta agonist. That's albuterol. Okay, so you're short of breath right now, you're wheezing, you can take inhalations of a short-acting beta agonist such as albuterol. So that's a rescue medication. Okay, people carry it in their pocket all the time for when they're short of breath. A long-acting beta agonist. So they've just taken a beta agonist and they've put it in a long-acting formula or molecule, and we call it a long-acting beta agonist. Salmeterol, okay, is a common one. What does that do? Well, compared to albuterol, which just bronchodilates for a few hours, salmeterol can be used for control throughout the whole day because it is bronchodilating for much longer. It's not used as a rescue medication. Okay, it's used for daily control of the asthma, but not the rescue. The only rescue is the short-acting beta agonist. Okay, glucocorticoids. Well, inhalers are probably the most common way of delivering glucocorticoids to the lungs because it's safe, and we can deliver the glucocorticoid through the inhaler to control inflammation. So that's what glucocorticoids do. They're anti-inflammatories. So we use them in asthma for long-term control. We use them in COPD to decrease the inflammation. In patients that are controlled on an inhaler form of glucocorticoids, we don't need to use oral or IV glucocorticoids. If they come in with a flare-up of COPD or asthma, and their inhalers aren't working, then we can introduce an oral glucocorticoid or an IV glucocorticoid, such as methylprednisolone. The oral one we typically use is prednisone. Okay. One thing to remember about an inhaler of glucocorticoids is you need to rinse your mouth out afterwards because of the risk of developing thrush in your throat. Okay. The other inhalers don't do that, but because glucocorticoids are immunosuppressants, they can cause local development of candidiasis, which we call thrush in the throat, okay, in the mouth. Okay, antibiotics. Well, what do we use antibiotics for? Well, typically pneumonia and a flare-up of COPD. We can also use it for a bacterial sinusitis. But remember, most of the conditions that we spoke about in the upper respiratory tract are viral. So laryngitis, rhinitis, and most of the sinusitis are viral. But if we think the sinusitis is bacterial, then we can use an antibiotic. Okay. In pneumonia, well, the most common cause of pneumonia is viral or bacterial. We typically can't figure out which one it is, so we always use antibiotics in pneumonias, since we can't be sure it's not a bacterial pneumonia. In patients with COPD that have a flare-up, where they're coughing more, they're short of breath, they're coughing up purulent phlegm, we start them on an antibiotic, and we also often start them on a glucocorticoid orally, such as prednisone, to reduce the inflammation. You don't need antibiotics in an asthma flare-up, okay? You just need bronchodilators, such as albuterol, an anticholinergic, such as ipratropium, to bronchodilate, and a glucocorticoid, whether it's an inhaler or an oral or IV. It just depends on the severity of the asthma flare-up. Monoclonal antibodies have come out for many, many conditions. Oh, let's just talk about leukotriene inhibitors. Sorry. So montelukast, it's not used very commonly anymore, but we thought it would be very effective because it inhibits leukotrienes, which are part of the inflammatory system. So we thought, fantastic, this is going to work for asthma, allergic rhinitis, all kinds of allergy-related conditions. We can still use it for someone with asthma. It's not very effective, so you won't see it very commonly. Okay? We can still use it for someone who has allergic rhinitis, but we typically use nasal steroids in the form of nasal sprays, right? So it's just not a common medication you see very often because the glucocorticoids are much more effective for the inflammation. Monoclonal antibodies, so these have come out for all kinds of diseases. So this particular one, they're all impossible to pronounce. So omalizumab, they all end in MAB usually, and these in this case used for asthma to stop some of the inflammatory process. This monoclonal antibody, that's how it works. So it's kind of a last-ditch effort. These are very expensive, and most people are controlled with their beta agonist, their anticholinergic inhalers, and their steroid inhalers, such as fluticasone. Okay, the majority of people. Antihistamines are typically used for allergies, so whether it's an allergic skin condition such as urticaria, or allergic rhinitis, or allergic conjunctivitis, which is allergies in the eye, and they just block the effects of histamine on the receptor cells. Okay? Nasal decongestants such as phenylephrine, so these can be bought as a spray or pill tablet form, and they vasoconstrict the blood vessels in the nose, allowing people to breathe better. Okay? Now, because they're stimulants, so phenylephrine or neosynephrine, they're all stimulants. They're alpha-1 agonists, so they stimulate the sympathetic system. Okay? So if you're taking this as a spray, well, that's fine, but you just can't do it for more than 4 or 5 days, because when you stop it, you're going to get rebound nasal congestion. If you take it as a pill form, well, you are stimulating the sympathetic system, because this is a chemical that stimulates the sympathetic system. So you may get hypertension. You may get tachycardia. It might aggravate glaucoma. So on those packages, you'll see when you're buying nasal decongestants orally, it's going to say do not take with hypertension, don't take with angina or chest pain conditions or cardiac conditions, because it's going to raise blood pressure and also raise heart rate. What's an expectorant? An expectorant is just, they don't work very well, by the way, so I don't advise patients to buy them. What are they supposed to do? They're supposed to just loosen the phlegm and the mucus off the bronchial walls. That's all they do. That doesn't make any sense. How can the medication you take orally somehow get into your bloodstream and loosen sputum on bronchial walls? So most of us don't prescribe them very often. I know they're very popular over the counter. Honey works best in any of them. But that's the mechanism, the supposed mechanism of action, loosening the mucus off the bronchial walls. What's a mucolytic, such as acetylcysteine? That's a medication that actually tries to break down the thick mucus. So patients with COPD or cystic fibrosis that have really thick, tenacious sputum that they can't cough up, sometimes we'll use acetylcysteine nebulized to get into the lungs and try and break up this thick mucus. Okay. Antitussive, what's that? It's a cough, just to stop a cough. So tussive is cough, antitussive is anti-cough. Are they very effective? No, not really. Dextromethorphan is a common one. It's a variant of an opioid. Honey is shown to be more effective as a cough suppressant. Okay, so a lot of them you'll see are honey flavored or honey added, and that's just to try and sell them. Tuberculosis medications we'll talk to in more detail. So there's a medication called isoniazid for latent TB, meaning someone tests positive on a TB skin test, but they don't have active TB. They don't have any symptoms. So, but it's to try and clear this latent TB that they acquired from somewhere that may be activated later in life. Okay, and then there's tuberculosis medications that we use typically in combination to try and treat active TB in the lungs. And it usually takes 3, 4 different medications combined to treat tuberculosis for a prolonged period of time. Okay, so it's typically taking these medications for 9 to 12 months, sometimes up to 2 years, to try and get rid of tuberculosis. Influenza medications, we're going to talk briefly about amantadine. Another one that you might recognize is Tamiflu, which is oseltamivir. They need to be taken early on in the influenza condition. And again, they're not very effective flu influenza. So typically they're taken in the first 24 to 48 hours. Well, how many patients know they have influenza in the first 24 to 48 hours of having symptoms? Not many. And on top of that, many of the medications have side effects, and they've really only been shown to reduce the illness by 6 to 12 hours. So not very effective. Many places have stopped using them because the evidence is very weak for their efficacy. Okay, we'll move on.